Dr. Walid Alhabashy is anesthesia and critical care consultant, works currently at Dorset County Hospital, Dorchester, United Kingdom. He holds the MD and Arab board in anesthesiology, 2 European diploma, 1 in anesthesia and the second one in critical care, and he also holds the Irish Fellowship of Anesthesiology, and he has finished a diploma in healthcare simulation and patient safety. Prof. Walid succeeded to publish many case presentation, case series, and RCTS in the field of critical care, echo, and ultrasound, which are his special interest. Prof. Walid also has a handbook available on Amazon on both soft and hard copies. Prof. Walid is the founder of Saving Lives Academy, which is helping doctors to conduct safe anesthesia and the critical care practice and promote their career as well. Please visit the website and YouTube channel to know more about this academy. This is Dorset County Hospital, where Prof. Walid work now. It started from 1991 and was established at May 8, 1998. It has 500 beds, about 3,000 employees in this hospital. This is the emergency department. All female, Dr. Walid, all female, all beautiful female, Dr. Walid. This hospital founded in Dorchester City, which is a great place for walking and exploring with numerous historical sites and amazing view. Very happy, very proud to introduce you, Prof. Walid, my dear son and my dear guest. Happy and proud to introduce you, and many thanks for all your endless effort you do for MAC. Thank you, Prof. Walid. Thank you.
Please, this is a long lecture, so feel free to bring your coffee, popcorn, or tea and attend, because it's a long lecture. I'm sorry, this is breaking the rules, and it's not a 20 to 30 minutes lecture. It may extend the 1 hour time. Housekeeping points. There will be a recorded session available for after 1 or 2 days on Saving Lives Academy YouTube channel and website, and on the MAC Telegram group or Menoufia Anaesthesia Club Telegram group as well. Please make sure that you use the chat box to ask your questions, as raising hands is not such helpful in that scenario, or at least tonight. Questions will be answered at the end of this session. At the end of this meeting, I will send an evaluation form. I will post it here. I will post it here in this group, so kindly, it takes less than 2 minutes. You will be watching and listening to me for like an hour or so. So kindly tell me how you feel about that. There are surprises. It's actually 3 surprises at the end of this talk, so I hope you stay with me until the end. It's a tough lecture, as I said. We are talking about the foundations. So great thanks in advance for who are staying with me until the end of the lecture and doing the feedback. I have no conflict of interest whatsoever to cover in this or related to this talk. And I want to remind everyone attending tonight that you are actually as strong as your foundations. So strong clinician, either anesthetist or intensivist, should have strong foundations. That's why we are starting tonight from the basic or the fundamentals of cardiovascular physiology, with impact on the anesthetist and intensive care doctors. So the objectives of tonight's lecture: number 1, we are going on the action potential explanation in full details, or the electrical activity of the heart, including the cardiac muscle cell and the SA node. Then we'll go to a cardiac cycle, then left ventricular loops, either pressure time loops or volume pressure loops. Then we'll discuss the serious arrhythmias, including the supraventricular tachycardias and heart blocks, simplifying the pathology as much as we can and making it easy to read the ECG as much as we can, with some clinical context as well, or putting that in its clinical context as well. Cardiac output and shock physiology, diastolic function or diastolic dysfunction assessment and its impact on the mortality in septic shock, which represents more than 50% of ICU admissions. And then we're going to the hemodynamic parameters cut-off values, which was a bit challenging in the last 10 years, which cut-off value to go with if I'm looking for stroke volume variation, pulse pressure variation, or CVP, or so on. So this is our objectives for tonight's lecture. I am not covering tonight the exercise physiology or metabolic equivalent of the tasks. I'm not having a look or emphasizing on coronary circulation, despite it's very important, but we cannot cover everything tonight, and we are not discussing most of the important pathologies like hypertension and cardiomyopathies. So I'm sorry if this is beyond your expectations. Let's start now by the electrical activity of the heart. So this is a cell, and we are discussing the electrolytes inside and outside and the concentrations of each, and then we can imagine if it is going towards inside or towards outside if all the channels are open. Kindly make everyone on board make sure that his mic is off during the talk. Thank you. So, 4 main electrolytes controlling all the action potential: sodium, potassium, chloride, and calcium. Let's start by the sodium. Sodium is 145 outside while 12 millimoles inside. So the concentration gradient of sodium comes from outside to inside if all the gates are open. We will imagine that sodium gates are open, which is not a true fact. So sodium will leak from outside to inside with the concentration gradient because it's 145 outside while it's 12 inside. Clear? Chloride is the same. It's 105 in the plasma or in the extracellular space, while it's actually 4 inside. So by concentration gradient, it will leak from outside to inside again. Calcium is 1.8 outside, while it's 0.0005 inside. So again, if all the gates are open, it will leak from outside to inside. So 3 of our anions and cations are leaking by concentration gradient from out to in. That's in contrary to the potassium, which is unique. So its mainly concentration is inside. And it's only 4 millimoles or milliequivalents outside. So if you allow all potassium channels or gates open, it will leak from in out. So this is a concentration gradient. There is an electrical gradient as well. Electrical gradient is negative inside the cell because the cells has proteins inside, while positive outside. With the electrical gradient, the resting membrane potential is minus 90 millivolts. So imagine if I opened all the gates for all the anions and cations, it needs to reach 0 potential. So there will be 2 different forces. One is the concentration gradient from out in, with all electrolytes except the potassium, concentration gradient will be from in out. And electrical gradient, which should equilibrate the electrical forces to make it 0 potential. That's the resting state. So again, concentration gradient and electrical gradient. Now let's have a close look on this equilibrium potential if we make it unique for every single anion or cation. the equilibrium potential for the potassium is minus 94. So if you allow equilibrium via the gates across cell membrane to have concentration in the same as out, so potassium will leak from inside to outside. If you are losing positive cations from in to out, this will make it more negative inside. So the resting or equilibrium potential for potassium is minus 94. In contrary to sodium, if it leaks from out to in, the concentration gradient, it will rest at 70 millivolts by positive charge. Calcium, again, because it's 1.8 and 0.0005 inside, will leak inside and do the resting membrane potential at positive 132. While chloride, again, with the concentration gradient goes from out to in the cell, so it will render the cell again more negative, and the resting potential or equilibrium potential for chloride is minus 85. Permeability for the potassium is high because there is ungated potassium channels, and this is the only high permeability in the resting condition, and that's really serious to know. While all the others permeabilities are very low because it is controlled via different gated channels. And here when we discuss the gated channels, you have to know that there is voltage gated and ligand gated and mechanical gated channels. Okay, so I want you to keep in your mindset at this stage, there are concentration gradient and there is conductance. And you need to understand what is conductance here. Conductance is the amount or the degree of freedom we are giving to the electrolytes if the gates here are increasing or decreasing. So increasing the conductance means I am opening all the channels to allow sodium or potassium to leak in or out. So increasing the number of channels increases conductance. Okay? Increasing the gradient between in and out increases the conductance if the gates are open. So again, we are controlling all our medicines we are giving to the critically ill patients or in anesthesia via this action potential. Everything is controlling the heart, and you will see via different examples through these different mechanisms. You are either causing change in the gradient or a change in the conductance. There are sodium gated, electronic gated or voltage gated channels and ligand gated channels. Potassium, there is open channels all the time, they are open, and there is voltage gated potassium channels. And this is slowly working channels in the potassium case, while it's very fast if we're talking about sodium channels. And you need to know that as well. I need you to imagine now if I opened all the voltage gated potassium channels and potassium leaks out freely. So I am increasing the conductance of potassium. So with the concentration gradient, it will leak from inside the cell to outside, making the cell more negative until it reaches the equilibrium potential, which is minus 94. And at this stage, the cell will be more negative inside. So it is hyperpolarized. So you need to bring it to depolarization, which is 0 or plus a little bit more distance. I hope that's clear. In contrary, or like the same, if you open the chloride channels and chloride will go inside with the concentration gradient, it will push the cell more negative and will hyperpolarize. In contrary to sodium and calcium, if they leak inside, they will make the cell more positive inside, and this is called depolarize. So you are losing the polarity between the negative and positive if you are leaking more positive ions inside or negative anions outside. Hopefully that's clear enough. We'll build everything upon this slide, so please raise hands if you didn't get this clear enough. Just raise hands, please, if anyone wants me to repeat that, because this is the foundation of everything. Let me repeat that again. So this is different concentration across cell membrane, making different gradients. Concentration gradient is one element, and conductance is the state of the and number of open channels allowing electrolytes to leak in or to leak out of the cell. So again, if you allow sodium to leak in, that is depolarization. If you allow calcium to leak in, that is depolarization. Chloride in, that is hyperpolarization. Potassium, if you open all the channels, it will leak outside. So again, hyperpolarization. Now, this is our action potential, is formed of 0, 1, 2, 3, 4 stages. In every stage, every electrolyte is behaving differently because the gates of this electrolyte is behaving differently. What are the gates I have? I have ungated potassium channel, and they are always open until your membrane potential reaches its resting state, which is minus 94. I have voltage gated sodium channels, so there is no open sodium channels in the cardiac muscle cells, it's only in the SA node. So resting state of sodium channels is closed. Voltage gated calcium channels, again the resting state is closed and it opens during depolarization. Voltage gated potassium channel, which is an add-on on the ungated potassium channels. So potassium conductance under the resting condition is high, but it's higher during depolarization. We'll see that in a minute. Again, these are the 4 stages. We'll go via channels one by one. This is the sodium channels. Once you reach certain electrical potential, which is minus 70 or 70 to 80, it allows all the fast sodium channels to open. And because it's very fast channels, it open and close immediately. Once this sodium channel opens, the permeability increase, so all the sodium or high amount of sodium goes from out to in. Okay? And once it is open, it closes. So this surge of sodium in stops and this flow is decreasing. So the permeability here on the y-axis increase suddenly because of gates are open and decrease suddenly because gates are closed. And this represents the stage 0 or phase 0. Once you open these sodium channels or fast sodium channels with depolarization, it will activate calcium and potassium channels. So action potential starts by activation of 3 different channels: sodium, potassium, and calcium, all of them together. But sodium channels are the fastest to act, so immediately depolarize, and again the permeability suddenly decrease when it is closing. Hopefully that's understood. So this is the sodium channels. This is the voltage gated. Once that happens, it stays with inactivated as a ligand gated potassium sodium channels. It will be inactivated for a while, so you cannot reactivate it immediately again. It needs reactivation, but after a while. Okay? This is the calcium. If you notice, sodium was going very fast and down very fast. Slow calcium channels are in the resting condition closed. With the initiation of depolarization, it will open as well via the voltage gated channels. So the resting is closed and slowly opens. And once it is opened, it starts to close, but it is a slow channel again. So it's slowly opening and closing. And there's a question here. if the action potential does not stimulate the sodium channel here, and sodium is for any reason is blocked, what will happen? Will I have an action potential? Definitely yes, but via the calcium channel, so your action potential will be very slow after that. Now, compare that to the potassium. Potassium, as we said, there's two gates for potassium. Open gates all the time, allowing potassium to leak from inside to outside. That's open gated. But once you stimulate the action potential, or the sodium causes the depolarization, it stimulates potassium permeability and gates are opening. Look here, compare that to the calcium and to the sodium. Sodium and calcium leak causes depolarization, so membrane potential is going from the negative to the positive. I need you to compare that to the potassium. Once you open the potassium channel, the voltage gated, not the ungated, potassium will leak from inside the cell to outside. So it causes hyperpolarization, as if it is leading the cell to be again negative or restoring the polarity of the cell. If it restores the polarity, it causes repolarization. Okay, repolarization here. Perfect. So we have now the three different anions and cations. Sodium fast channels, slow calcium, and slow potassium. And this is the first stage, or stage 0, or phase 0. Then the plateau, because the calcium is opposing the potassium. Calcium is going in, potassium is going out. And then once calcium is open, potassium will be decreasing again to the repolarized state, or repolarization. This is what we mean by the action potential. Trust me, it took me long time, ages ago, to understand these 4 phases. So phase 0 here is the sodium channel. 1 here because of the closure of the sodium, and potassium is leaking outside still via the both gated and ungated. It's leaking out, so it goes back down. Then when the calcium is open, calcium is rushing in, calcium is still leaking out, so it creates the plateau phase. Once the calcium is inactivated, potassium is unopposed, causing repolarization. So at phase 0, sodium channels are open, so sodium in and potassium out via ungated. In phase 1, sodium is closing, potassium is still leaking out only via the ungated. At the stage 2, the ungated and gated potassium channels both are open, while calcium is open. Potassium voltage gated is open here to the maximum, so it drives everything down back to the repolarized state. At the stage 4 here, both are still open, gated and ungated, and this is the only stage where potassium gated and ungated channels are open. All other channels are closed. Again, sodium in, potassium is continuously leaking outside. Here, ungated is in equilibrium with the calcium. Once you activate the full power of the voltage gated potassium, it causes repolarization, and at this stage 4, or phase 4, both potassium gated and ungated channels are open. During this one, once you reverse the polarity and cause action potential, you have one more thing running in the background, which we call sodium-potassium ATPase. Sodium-potassium ATPase, or ATPase, is an enzyme that again push the sodium from inside the cell to outside and potassium from outside to inside, restores the normal balance. Okay, and this is an active process that needs energy. Let's imagine now sodium channels are off. There is no sodium channels in the body. As I said before, depolarization will happen via the calcium channels. So it will be happening, but very delayed here. So this, instead of this fast upstroke, will be very slow. And this what happens actually when you give local anesthesia intravenous. Potassium channels are not closing. Imagine with me, the potassium channels are not closing. The voltage-gated potassium that opens here are not closing. So repolarization will happen faster and more effectively. If the potassium channels, the voltage-gated, did not open, so the repolarization will happen very slowly via the ungated channels. Okay? This is, I hope that is understood. Please raise hands if you want me to repeat. I'll wait for a few seconds. Okay. So this is the electrical activity or the action potential. And this is the muscle twitch. This is the absolute refractory period, and this is the relative refractory period. The message I want to deliver here, you cannot tetanize the muscle cells of the heart because of the long absolute refractory period. Compared to the normal muscles that can get tetanus or tetanic, not tetanus, tetanic or tetanic contraction, because of absolute refractory period would be shorter or halfway only compared to this very long absolute refractory period of cardiac muscle cell. So if you see the muscle contraction compared to the action potential of the cardiac muscle cell, this is, you cannot tetanize the skeletal, you can tetanize the skeletal muscles, but not the cardiac muscle cell. Now let's jump to a different cell, which is the SA node cells. SA node does not have the plateau phase, that's number one, but more importantly, there is a continuous sodium or calcium inflow. There is gates that allows continuous leak from outside to inside, and in different physiology books, some authors say it is sodium channels, others say it's calcium channels, but continuous leak from out in. Once you get this from minus 60 resting potential in SA node cells to minus 40, because it's leaking from out in, with the concentration gradient, which has more sodium and more calcium outside. Once you reach the minus 40, again the fast sodium channels open and it jumps to positive 20. And once you reach this stage, potassium efflux rushes again outside and repolarize. So if you remember our conductance, the conductance is the number of membrane of gates open. If you increase potassium conductance, you are allowing more potassium to leak from inside the cell outside, so causing hyperpolarization. If you decrease conductance, you are minimizing potassium leaving from in out, so that's again depolarization. So stage 4, or the membrane potential or threshold potential, you reach via two different mechanisms: continuous leakage of sodium or calcium, depending on the theory you read, plus decreasing the conductance of potassium. That's very important, because this is how noradrenaline and adrenaline and acetylcholine work. If you want to make that one faster, decrease this one to the minimum, and if you want heart rate is slower, change this one. So decreasing conductance makes the heart rate faster. Increasing the conductance of potassium, it will resist this sodium inflow, so it will make the heart rate slower. This is the firing of the SA node. Again, epinephrine works via 3 different mechanisms. It increases the sodium conductance, it increases the calcium conductance, so it allows more calcium and sodium in, while it decreases the potassium conductance or permeability. While acetylcholine works via only one mechanism, which is increasing potassium conductance. Okay? So, in a nutshell, let's review the change, the voltage, the magnitude and application of this form. Here, let's have a look. If you increase the potassium concentration outside, what's the effect of that? If you increase potassium outside, you will minimize potassium leaking from in out, so you will prevent hyperpolarization, as if you are helping the depolarization, and the magnitude of that is very large on the resting membrane potential. That's why we are afraid of hyperkalemia much more compared to hypokalemia, because you are helping depolarization, so you may lead to VFib arrest with the hyperkalemia, because easy depolarization. Imagine that you decrease the conductance, it will lead to the same effect, because I'm not talking about concentration here. If you decrease leaking out of potassium, so you are preventing any hyperpolarization, so as if you are causing depolarization, and again that has an impact which is high on the resting membrane potential. Now, if you increase concentration of sodium, how many times you saw hypernatremia with no impact on the ECG? There's no impact on ECG for hypernatremia. Why? Because despite the concentration change, if it goes to 160 or 170 even of sodium, we have only voltage-gated sodium channels that prevents any leak or any depolarization. Depolarization only happens at this stage when the gates are open. Faster or slower, it will happen anyway. But again, concentration is not the player here like potassium. Potassium, the concentration and conductance plays role because it is ungated potassium channels. If sodium, and I hope you still focused with me, if sodium has ungated channels the same as potassium, it will be the same. But increasing concentration has no impact. Increasing conductance means if you are opening more channels in the cell membrane, because sodium gradient is higher than potassium gradient, it will have a great impact on the action potential. So increasing conductance or increasing permeability to sodium will have a great impact on the action potential. Compare that to chloride. If you increase the concentration of chloride in hyperkalemic metabolic acidosis, for example, it will cause hyperpolarization of the cell membrane. That's a good example of acidosis. It has a moderate impact on the cell membrane potentials. While if you increase the conductance, you will allow more electrolytes or more chloride ions to leak from outside to inside of the cell, making the cell again hyperpolarized. So again, let's review. If the cell is hyperpolarized, you are inhibiting the synaptic transmission of all cells. So concentration, major rule is for potassium. Concentration or conductance of chloride causes hyperpolarization. Sodium conductance is very important, while concentration, because there is no ungated channels, is a minimal rule or trivial rule. If you decrease conductance, this will have a great impact in the term of depolarizing the resting membrane potential. Please raise hands if anything unclear now. Now, the clinical application, as I said, the first thing here is the local anesthesia toxicity. Agents of local anesthetics are attached to the intracellular sodium channels, which are the fast sodium channels. If you block it or you inhibit it, you inhibit depolarization. imagine that you are giving that intravascular. So it binds to the sodium channels, potassium channels, calcium channels, and it binds to the sodium-potassium ATPase. That's catastrophic. There is no action potential in the SA node. There's no action potential in the AV node. And even the Purkinje fibers cannot contract because there is no action potential. That's why you need to give the intralipid, which will act as a physical carrier of your local anesthetic, and by concentration gradient, it will leak outside by concentration gradient to the intravascular space, leaving the cells alone. And during that time, you are doing the CPR. So local anesthesia toxicity is catastrophic because of that. And that's why we say don't give lidocaine if you have a patient with local anesthesia toxicity, because you're just worsening the case. You're just preventing more action potential, because this is the mechanism of action of all local anesthetics. Acidosis and alkalosis and impact, again, it is acidosis with hydrogen-potassium exchange. It will cause hyperkalemia. If the potassium is higher outside, you are preventing leaking of potassium from inside the cell to outside, so you are causing depolarization. You are making cells more irritable. In contrary to alkalosis, hypokalemia will allow potassium to leak from inside outside, which will render your cell hyperpolarized. I'm keeping repeating that again and again and again, just to make it easier to stick to your mind. Diarrhea and diuretics, potassium loss. If you are losing potassium, again, the issue here is hypokalemia. Hypokalemia, you are making more gradient, concentration gradient, so via the ungated potassium channels, potassium will leave outside, render the cell hyperpolarized, or the resting membrane potential will become more negative. I am not afraid of hypokalemia, the same as hyperkalemia, because one is stabilizing the cell or making the cell hyperpolarized compared to a cell which is depolarized. One of the challenges I find in pharmacology is to understand the mechanism of action of digoxin, and this really needs a graph. So there is something in our cell membrane called calcium-sodium exchanger. So this is money exchange. This is exchanging calcium for sodium. If you have low sodium in, that means I need to bring more sodium from outside the cell to inside to maintain my balance. And if sodium is going in, calcium will leave out. Actually, to enhance the contractility, you need the calcium to stay inside. So you need to fight any hyponatremia. You need to maintain a good sodium level inside to prevent any concentration gradient leak from out to in. Again, if sodium stays in, calcium stays in. Clear? In order to keep calcium inside, you need to keep sodium inside the cell. Here, this is the sodium ATPase, which we mentioned a minute ago. It exchanges the potassium to sodium. So, to neutralize the cell after the action potential, it brings the sodium back out after leaking inside during the action potential and brings the potassium in again. So it's an active pump because it's working against the interest of the concentration gradient for both sodium and potassium. If you work against the nature, you need some energy. Here we go. Now, if this is bringing sodium out, so it will make the cell inside low of sodium. I need to keep sodium in to keep calcium in. This is taking my sodium out. I need to stop it. That's my digoxin. So digoxin works on the sodium-potassium ATPase to block it. So it will prevent sodium going out. It will keep the sodium in, and it will keep the potassium out. If you keep sodium in, you keep calcium in, you improve the contractility of the cardiac muscle cell. So the side effect of digoxin is potassium high outside. because it prevents the sodium-potassium ATPase, so it leaves sodium inside and it leaves the potassium outside, so the adverse effect of digoxin is hyperkalemia. Why I am teaching all of that? Because imagine how many patients came to you in ED with hyperkalemia. What is the anti-hyperkalemic medications you give? Dextrose insulin, salbutamol nebulizations, and calcium. In this case of hyperkalemia, in particular, calcium is contraindicated. Do not give calcium, please, in digoxin-induced hyperkalemia. Because you have plenty of calcium intracellularly, you don't want to aggravate that effect of hypercalcemia intracellularly. So this is the only occasion you don't give calcium to stabilize the cardiac muscle cells against hyperkalemic effect, if it is digoxin toxicity. Long story short, if you are in ED and a patient came to you with hyperkalemia and you want to start anti-hyperkalemic measures, please remember to ask, is this patient in digoxin? Is there any chance that this is digoxin toxicity? Yes, no calcium, no, give calcium. First drug you give is calcium, if it is not digoxin induced. Now again, this is my normal SA node action potential, and as I said, acetylcholine does its action to lower the firing rate of SA node just by increasing the potassium conductance. So if you increase potassium conductance, potassium will leak from in out, make the cell more hyperpolarized. So to make the depolarization, it takes longer time for more sodium to diffuse in and then fire the action potential. In contrary to epinephrine, which works by 3 different mechanisms of action, one is decreasing the potassium conductance, increasing sodium and calcium conductance. So calcium, sodium increase, and potassium decrease. Let's have a discussion on the cardiac cycle now. This is my action potential, and this is the P, QRS, T, and where is my action potential on the SA node or cardiac muscle cells. Here, the R is correlated with phase 0 and 1 of the action potential. The plateau phase is the ST segment interval, while the repolarization is the T wave. Remember, until here is the absolute refractory period. From this area to this area is the relative refractory period. The worst and most serious arrhythmias are the R on T. R on T, when you induce a new R wave in the relative refractory period. At this stage, the cell did not repolarize yet. Inducing a new action potential at this stage may cause a VFAP. That's why it's a nightmare to see R on T in any arrhythmias. R is an R wave while the patient had a T. Okay, so what will cause R on T? Any drugs causing prolongation of the QT interval. This will increase the incidence of R on T, like quinine, procainamide. All these drugs prolonged the QT interval. So again, if you are on any of these drugs, you need to do ECG on daily basis to look at the QT and maintain that below or within the normal range, which is 480 in some references and up to 500 in different rhythms. Now, cardiac cycle is formed of either systole or diastole. Systole is either atrial systole or diastole, or ventricular systole and diastole. The start of the atrial systole is just after the electrical conduction on the atrium, which is the P wave, and this is all atrial systole. Atrial diastole is masked by the QRS-T complex, or from the Q till the T. This is the time my atrium is repolarizing. While the ventricular systole starts from the R and ends by the T, so anything after the T until the next P wave is a ventricular diastole. So the complete cardiac cycle is from the beginning of the P to the next P. So atrial systole, again after the P until R, and then diastole, ventricular systole from the R until the end of the T, and then ventricular diastole. And this is a complete cardiac cycle. Is that important? Definitely. If you are to do echo at bedside, you need to time your ECG with the echo. If you are listening to any murmur, you have to put that in a context of the pulse. Is it a systolic or diastolic murmur? You have to correlate that with the pulse. Your understanding of the cardiac cycle is extremely important. So let's start the cardiac cycle from systole and diastole as we had agreed on. And we are talking about the ventricles here. Ventricular systole and ventricular diastole. The ventricular systole is divided into two stages. The first stage is the isovolumetric contraction and starts from the R wave until the end of the S wave. And this isovolumetric contraction, it's named the isovolumetric. So there is no change in the volume of the left ventricular size. So the contraction here is like a static contraction or no change in the volume. There is no valves open. The mitral and aortic are both closed. Mitral and aortic valves are both closed at this stage, so there's no change in the volume. So that's why it is isovolumetric contraction. Followed by the ejection phase until the end of the T wave. Ejection phase is when I am ejecting all the blood from the left ventricle to the aorta. So the aortic valve here is open. So if you're looking for an aortic stenosis or ejection systolic murmur, you need to monitor at this stage, at the end of isovolumetric contraction with the beginning of ejection or early ejection systolic or mid-ejection systolic or late ejection systolic murmurs. So diastole will start by the isovolumetric relaxation. So the pressure starts to drop and aortic valve close. So once aortic valve and mitral valve both are closed, this is the time there is no change of the left ventricular volume while the ventricles started to relax. So it starts to relax and create negative or relatively negative pressure. So this is the isovolumetric relaxation phase, immediately after the T wave. And then the mitral valve opens and start to do the passive filling phase. So blood will go from the left atrium to the left ventricle and from the right atrium to the right ventricle. And then a stage of diastasis. And this is very important to understand for understanding diastology and diastolic heart failures and to interpret your echo properly, because this is a killer. So please, I need your full attention here. Diastasis is the stage that the left atrial pressure is equal to left ventricular pressure. So the blood is not flowing anymore. So there is no flow at this stage between left atrium to left ventricle. Yet there is still some blood in the left atrium. So this will stimulate the left atrium to contract, which we call it the atrial kick or atrial contraction, which is responsible for filling of the LV at the end with 15 or 20% of the LV volume. So let's have a look on the pressures and volume curves. The pressures here. So if I am talking about isovolumetric contraction phase, the both valves are closed. So I have no flow in this stage. Pressure here is equal between left ventricle and aorta. Once pressure in the LV exceeds the aorta, aortic valve opens, and I'm starting to eject the blood from the LV to aorta. So the pressure is increasing here. So this is aortic and left ventricular pressure will keep increasing because the ventricle is squeezing the blood out. Until I finish and my pressure goes gradually down until the pressure in the aorta is higher than the pressure in the LV. At this stage, pressure in LV starts to drop, while in the aorta, because it's a competent valve, stays high. So the pressure, systolic pressure in the aorta is 120, diastolic pressure in the aorta is 80. And then LV pressure will continuously drop until 0 to 10. compared to 80 of the aortic pressure. So again, isovolumetric contraction, pressure of the left ventricle in green is going up until it exceeds the aortic pressure, so it opens the ejection phase, so aortic valve is open and mitral is closed. Pressure started to drop in the LV, until LV pressure is below the aortic level, so here the aortic valve is closed. It will start to drop until it is below the mitral valve pressure or the left atrial pressure. If the pressure in the LV less than the left atrium, at this stage the mitral will open. And at this stage, we have to look at the volumes. Volume here in the LV is increasing, and then static. This is what we call diastasis, or no flow from the LA to LV. And then the atrial kick will push more blood to LV, causing increase in LV volume. If you compare this volume to this volume, we'll find it 15 to 20% of the LV filling volume. And this is the ejection. So here the LV volume is decreasing. No change because both valves are closed. No change here because both valves are closed. No change here because left atrial pressure is exactly the same as left ventricular pressure. And here the volume is increasing because the left atrium is squeezing the blood, 15 or 20% of the volume remaining here. So this is the contraction phase, relaxation, filling phase. The aortic valve is open here and closed here. The mitral valve is open during this filling phase and closed here. Last and not least is this one. This is the killer of diastology. I'll show you by evidence towards the end of this lecture that diastolic failure is a killer, while systolic failure is not, by the current evidence. E is the early filling phase of the LV. Then no change in the volume and atrial kick. This is what we call EA of Doppler signal on the mitral valve by echo. That's why if anyone comes to you, says this patient has an echo and he has ejection fraction of 55% or 60% and full stop, that's not enough. This is not what I'm afraid of to put this patient asleep. If he has a systolic failure or if his ejection fraction is 35%, I can add inotrope or I can put dobutamine, adrenaline in a central line. I'm not afraid of that. I can improve that during surgery, and after the surgery I can stop it again. This is not what I'm afraid of. I'm afraid of something that cannot be treated, which is called diastolic dysfunction. If this patient has diastolic dysfunction and there is something coming in the last 10-15 years named HFpEF, heart failure with preserved ejection fraction or with normal ejection fraction, HFpEF is a killer and it kills more than systolic dysfunction. Here, before we finish this one, I need to go on these jugular venous waves. And the jugular venous waves, the A here is for the atrial contraction after the P wave. C means the filling. C here is the ventricular contraction. C is for contraction of the LV. So the contracting LV. So the contracting LV will push the mitral valve a little bit up in the LA. If this goes up, that means a positive wave. And then once the mitral valve opens, it causes this X descent. And LV starts to fill the blood. So this is the V, or the increasing volume. And in the increasing volume, as you know, there is isovolumetric relaxation phase at this stage, which causes dip on the LA pressures, again the Y descent. So if you are pushing the mitral valve up, it will make C, or positive wave. If you are filling the left atrium or the right atrium, the same here. So if you are filling blood, this will increase gradually until you open the mitral valve. At this stage, will cause a Y descent. So Y descent here means the mitral valve has opened, so all the volume in the right and left atria is gone to the ventricle, so decrease until the atrial kick or atrial contraction. So A is the atrial contraction. C is the ventricular contraction, which is the isovolumetric contraction phase, pushing the mitral valve up, so increasing the pressure in both left atrium and right atrium and in your jugular veins subsequently. X here means I am relaxing, I'm ejecting more blood outside, but I am starting to get rid of some of the blood, or the pressures decreasing in the jugular veins, will build up the pressure in the veins afterwards, because I am filling. At the same time, I'm ejecting the blood from LV outside to the aorta and from right side to pulmonic. I am starting to fill back from the venous return, so it will increase. And at the end of this one, in the isovolumetric relaxation phase, the pressure drops and then ends up by atrial kick. Hopefully it is well understood. Now, do you want to break for 5 minutes? Prof. Safa, it's 1 hour now. I know it's a very tough meal. What do you think? 5 minutes break or continue?
5 minutes breaks ولا عايزين تكملوا يا جماعة؟ مكملين مع حضرتك.
Okay, if you want a 5 minutes break, I'm more than happy. Raise hands, please. I know that you may not be able to write in the chat.
لا يعني okay. Everything is okay for us. If you want Dr. Walid, okay.
I can see few messages coming here as نكمل. Okay, let's continue. Thanks so much. Perfect. Thanks so much. Okay, so you can review that because it will be recorded and it will be available. So if you find something or certain bit of this lecture is difficult, you can go and review it again. So this is the pressure time. If you are preparing for any exam, please look at the pressure is coming before what. This is what's important for you. If they're asking you to write on pressure time, this is what they are asking for. If you are asking to pressure volume, this is what they are looking for, which they are completely different. If you write that one, you get 0 if you are answering this question. You got, for all people preparing for the FRC exam, FCI exams, European Diploma exam, it's very common in exams. And you need to be understanding what they're asking for to write a relevant answer. Sorry. So here, this is a pressure versus volume. And we are talking about the left ventricle. So this is the left ventricular pressure, and this is the left ventricular volume. It never goes back to 0 because pressure is never 0 at the volume. So my structure or my curve starts at this point. Let's do the same what we did here. We are starting here from the mitral valve closing, going towards aortic valve closing. So isovolumetric contraction phase. I need here the isovolumetric contraction phase to make it easier for yourselves is to start from here. So here, before contracting the left ventricle is at the maximum left ventricular end diastolic volume. So I have 120 mL of blood here. So mitral valve is closing, isovolumetric contraction phase until pressure in the LV exceeds pressure in the aorta. So the aortic valve is opening and I'm ejecting the blood. If I am ejecting blood out of the LV, so I'm expecting the volume to go from 120 down to 50. So this is my 70 mL of stroke volume. Until the pressure drops again, so the pressure in the aorta is higher than the pressure in the LV, so the aortic valve closes. At this stage, pressure continues to drop with the isovolumetric relaxation phase. Pressure continues to drop down, down, down until it is less than the pressure in the left atrium. So the pressure gradient is from LA to LV, so the mitral valve will open. And again, if the mitral valve starts to open, you start diastole and left ventricular filling. So the difference between this one and this one is actually the stroke volume, 120 to 50. So my stroke volume is 70. So this is the end systolic volume, and this is the end diastolic volume. This is the end diastolic pressure, and this is the end systolic pressure in the LV. It's easy as such. Isovolumetric contraction, isovolumetric relaxation, end systolic volume. Okay, so this is a pathological curve, shows what happens in aortic stenosis. The volume stays the same in the LV or getting a little bit smaller, but the main changes here is in the systolic pressure. So systolic pressure is getting higher and higher and higher because the difference between the pressure in the aorta is higher than the pressure in the LV. The pressure gradient is towards increasing via the pathology on the aortic valve. So aortic stenosis causing aortic valve to get thicker and thicker and thicker. And this is what we actually measure in echocardiography. We measure the pressure gradient. If you get that term, it represents the severity of the aortic stenosis. So the pressure gradient is higher, so that means it is higher in the aorta more than the LV. Okay, sorry, it is higher in the LV more than the aorta because the stenosis is coming from downstream. So LV pressures are high, aortic pressures are low. The more the gradient, the more severe is the stenotic lesion. And if it is severe or tight aortic stenosis, that means all the pressures built up in LV are not reaching your systemic circulation, and subsequently low cardiac output manifestations. So everything happening in your aorta is very low, is not enough to perfuse your brain, your heart, so you get a myocardial ischemia, myocardial infarction, or fainting spells. So again, how to discover that? Put your stethoscope on the heart and see with the pulse if it is a systolic murmur. Assess if it is a systolic murmur. You can have one of two systolic murmurs. It's either aortic stenosis or mitral regurg. I am so afraid that aortic stenosis is a killer, particularly if you're giving spinal anesthesia for a lady. So if you want to use a stethoscope for just one thing in your life, it is a cesarean section or a female coming for a section and in the aortic valve. It's a killer. If you cause hypotension or decrease in systemic vascular resistance, you are aggravating the gradient between the LV and aorta, which may cause arrest. And if it happens, it is a one-way arrest. I'm afraid it's very difficult to restore the cardiac output the patient was living with, because in recorded studies, that your cardiac output is representing like 30 to 40% of the normal cardiac output of the patient. So if you are surviving with a tight aortic stenosis or severe aortic stenosis, it will be very hard task for you to achieve that in a post-arrest scenario. Okay? If you find the gradient low in a patient with a higher gradient previously, that's not a good omen because the valves does not correct themselves until they had surgery. So this is what we call a severe aortic stenosis with a low flow. So that's a failing left ventricle. So if you find the gradient was 70 a year ago and the gradient now is 50, definitely that his ejection fraction is less. Now, if you compare that to the aortic regurg, the stroke volume is increasing because the end diastolic volume and end systolic volumes. So you see here, this is the end diastolic volume. It's increasing because maybe 20-30% of what is leaving out the LV is coming back, leaking back because of aortic insufficiency. So in aortic regurg or aortic insufficiency, the volume is increasing. While in mitral stenosis, the problem is not in the LV, so the pressures are maintained until it is really severe mitral stenosis, but the stroke volume is decreasing, so pressures are slightly decreased until it is severe or very severe or tight mitral stenosis. But what happens is the stroke volume is getting smaller because the venous return from the left atrium is getting smaller because the area is getting tighter. So this is 3 examples of mitral aortic valve lesion, how it affects the pressure volume loops. In myocardial ischemia and failing heart, the volume is slightly decreased, but contractility and blood pressure is getting again smaller and decreasing because of the failing myocardial cell contractility power, and we'll have a look on that in the coming few slides. Now this is left ventricular contractility or systolic performance compared to the ventricular preload, and we call this curve the Frank-Starling curve. All of us know that it's increasing until certain limit starts to go down again. And in many exams, if you're preparing for exam, they will give you these dots with names, and it will ask you what is normal to A. That's any case scenario with hypovolemia, dehydration, diarrhea, running a marathon without drinking, So usually it goes on the volume curve. So here the volume dropped, and subsequently systolic performance is getting lower or hypotension. So what is A to D? This is the normal compensatory mechanism. So if I am getting dehydrated, my sympathetic nervous system starts to work, so it increases the heart rate and contractility, trying to compensate. But does it reach the normal? Never. So it's an extra effort on the heart, but without not reaching the normal level, because this is a sympathetic fight or flight mode. When you reach the normal, after you resuscitate your patient and give him some more fluids, so his sympathetic reflex is now blunted because you are giving him what he lost. If it's a hemorrhagic shock, give him blood. If it is hypovolemia like dehydration or diarrhea, give him crystalloids, just restore the normal. Should be clear, crystal clear in your minds, that again, this compensatory mechanism does never reach the normal. You may find the blood pressure is normal, but I am talking about systolic performance here. That's a hyperdynamic heart. That's a heart which is struggling to compensate the mean pressure to maintain a normal perfusion pressure to all organs via exerting more effect. That's why if you have a sick heart responding with more tachycardia and more contractility, it's trying to squeeze the small volumes that he got from the venous return, this may itself induce a myocardial ischemia and MI for a sick heart. So what is normal to be? Normal to be is any volume expansion. So I was sitting, suddenly I drank 2 or 3 liters of fluids, or I'm giving that intravenously. And this is subsequently accompanied by decreasing the heart rate as a reflex. Okay, but here, if this is the normal, what is C? C is a muscular exercise. And if you're talking normal to E is if I increase my contractility and in the same time I got 2 liters of fluid bolus. This is what the marathon people doing. So they take good hydration and then run, increase the inotropic state of the heart. This is how they reach the maximum level of myocardial performance. Fortunately, they don't have a HOCM or HOCM with SAM. At this time, they get a myocardial infarction because of the tachycardia and oxygen demand supply mismatch. What is the abnormal conduction pathways? So if I'm talking first normal, what is the normal conduction pathway? If we talk about supraventricular tachycardia or tachyarrhythmias, there is atrial tachycardias, atrial flutters and fibrillation, AV nodal, AV re-entry tachycardias, and AV nodal re-entry tachycardias. The normal conduction pathway, as you may know, and as I'm expecting you all to know, is SA node is sending firing impulse that pass with the atria, reaching the AV node. AV node send via the normal pathway. the impulse to the bundle of His, to the Purkinje fibers via the LV, and this is the normal pathway. So we have two types of re-entry tachycardias, AV re-entry tachycardias and AV nodal re-entry tachycardias, and it's very important in our critical care life to understand the difference and distinguish between both of them, not to kill a patient. So re-entrant tachycardias are in the node. This is AV-NRT. In the AV node, there is an abnormal pathway. They call it slow-fast pathway. This is abnormal cells or abnormal bundle of cells or abnormal muscles, which is conducting the impulses. Actually, it responds slower, but the absolute refractory period is actually shorter in these muscle cells or in these cells. So it responds slower, but the absolute refractory period is shorter. So if I am sending both to the normal pathway, which we call it fast pathway, and the slow pathway, which is the abnormal pathway, which is either congenital or because of myocardial infarction or because of anything, it is blocked because the absolute refractory period was here in the first time. So this will allow the impulse to go only via the fast pathway and nothing happens because it's a normal P, normal QRS complex. The problem happens here when it is not in the absolute refractory period. You stimulated both ways. So this is responding now faster because it has recovered from the absolute refractory period faster. So the next beat will come two pathways, and as you know, flow always go to the area of the least resistance. So it will find this is an easier pathway, while this fast pathway is still in the absolute refractory period. So it cannot pass from here. It can pass only from this one. And if it goes here, it will stimulate the bundle of His and it will create a vicious circle, or will create another loop and loop and loop. So there is no more P waves, only what you see is QRS complexes. So it will create a vicious circle of repeated stimulation of the AV node. There is actually, maybe you find a P wave traveling up to LA, but it will be buried here in the QRS complexes. Is that important? That's very important. If you have any reentrant tachycardias, what are the medications you should give? So you should know what is the physiological basis behind. This is an AV re-entry tachycardia, and the most common example for that is the Wolff-Parkinson-White syndrome or WPW syndrome. So the bundle of Kent or the accessory pathway is present in the AV connection, in the atrioventricular connection. So it's a muscle bundle that allows, after stimulating the AV node, going to the bundle of His, to the Purkinje fibers, it should end here, but it will find an accessory pathway which can allow this one to go back to the AV node and stimulate it. And actually, once you stimulate that, you will go in vicious circles. There are two types of re-entry tachycardias here. One we call is orthodromic, and one we call antidromic. So if you have an orthodromic, you can still use calcium channel blockers type C or class 1C of antiarrhythmics to control that one if it is orthodromic. Well, actually, if it is antidromic, so the orthodromic is coming this way, the antidromic is coming from down up in a way or another. I don't understand that. I'm not interested actually to know what's the difference between ortho and antidromic. This is a cardiology-based understanding. But what I know is that antidromic, you should avoid all AV nodal blocking agent, beta blocker, calcium channel blocker, even digoxin. You cannot use any of these antiarrhythmic drugs. So, long story short, follow the ACLS guidelines. If it is hemodynamically unstable patient, you give synchronized cardioversion. If it is pulseless VTAC, you give a DC shock. If it is a stable, please, if you are considering SVT or supraventricular tachyarrhythmias with aberrant conduction or with aberrancy, please call the cardiologist. It is serious. Don't give any AV nodal blocking drugs. Don't give any calcium channel blockers. Don't give amiodarone. Don't give digoxin. Don't give any of these antiarrhythmics. Patient is stable. Don't make him unstable. If you give any of these drugs to the antidromic atrioventricular reentrant tachycardias, you are worsening the case and it may proceed to a VFAB or worsen the hemodynamics unindicated. Again, saving lives is my task here. So the take-home message in a nutshell, if you have unstable tachyarrhythmias, the patient is pulseless, it's a VC shock, pulseless VTAC or VFAB. If it is VTAC with pulse in unstable patient, that is a synchronized cardioversion. If he is stable, please do 12-lead ECG. Try to differentiate. There is Brugada Criteria, if you wish to read more about that one, which will guide you about which is high likely to be supraventricular tachyarrhythmias with aberrancy, or a VTAC as a ventricular tachycardia, not a supraventricular tachycardia. This is what they call Brugada criteria. I tried many times to understand that. It's not my field. I'm not a cardiologist. I call cardiologists, and even the cardiologists sometimes get confused and they err to the safest solution, which is electricity. So if you are in doubt, electricity is safer. This is in a nutshell. Now, the gift of tonight, the first gift of tonight, in heart blocks. A very easy map to heart blocks. I used it for years and years and years, and it never failed me. Look at RR interval and then PR interval. If the RR interval is constant, that's either first degree or a complete heart block. If the RR interval is variable, that's definitely a second degree, and we'll go after that to know is it Mobitz 1 or Mobitz 2. Now, if it's first or third degree, look at the PR interval. If the PR interval is fixed, that's a first degree. If it is variable, it's complete heart block. If the RR interval is variable, so it's definitely second degree, look again at the PR interval. If it's variable, Mobitz 1, fixed, it's Mobitz type 2. Let's apply that. Okay, so here I have the RR interval fixed, and I have prolonged PR, so it is not a normal sinus rhythm. I need to know, is it a complete heart block, or it is Mobitz 1, Mobitz type 2, or just simple first degree? Look at RR, it's fixed. PR is prolonged but fixed. Again, go with the diagram. Constant RR, fixed PR interval, that's first degree. Compare that to this one. RR is obviously irregular, variable degree between RR. Look at the PR interval, that's variable. This is a small, this is large. I'm not concerned with this one because there is no R here to compare. So neglect the P, unconducted. Look at the conducted P waves. Here it is variable. So RR variable, PR is variable as well. Variable, variable, that's Mobitz 1, Wenkbach's phenomena. Look, PR prolongation until a dropped beat, but I discovered it earlier than this. Here, RR is variable. PR for conducted beats are similar, same. So RR is variable, PR is fixed, that's Mobitz type 2. Could be 2 to 1 block, 3 to 1 block, I don't care. I don't calculate the P unconducted. Here RR interval is fixed, PR is variable, RR constant or fixed, PR is variable, we have a complete heart block. Easy, easy, lemon squeezy. Now, cardiac output and shock physiology. There is a concept in the Frank Starling curve called LO, or optimum muscle length. The best contractility you can get is when every actin is attached to a myosin, or whatever you call this actin and myosin in cardiac muscle cells. Actin myosin is the names in skeletal muscles. But again, interlace or intervention between two molecules of actin and myosin or something similar to that. So if you get it fully interlacing to each other, this is the best contraction. As you see here, with a lower volume, you get a lower stretch. So some molecules are not functioning or not recruited in this contraction. So this is a lower contractility, shorten the muscles. Overstretched muscles, you are losing some molecules here, not interlacing or interacting. So you are failing because of stretched muscles. That's why hypovolemia and hypervolemia are both enemies for you. So suppose I lost some fluids in the normal state. This is when I need to restore that. But the question here, is this only one curve that everyone is following? And the answer is definitely no. So here, this is the normal. This is the one with exercise that we had seen a while ago. But there is an exercise heart, but sick heart, and fatal myocardial depression. And the sicker the heart, the curve is getting flatter. So see how steep is that curve and how late is that point to go down. It's almost never going down in normal and hyperdynamic heart. But here, midway, you start to fail, you start to go down. And even for fatal myocardial depression, you have this is a flattened part. So that your chance in improving your contractility with increasing that or increasing your ventricular performance with increasing the volume is getting slimmer. Okay, so this is when you need to behave vigilantly. You have to see how the heart is contracting. Is it a hyperdynamic heart? Is it a normal heart? Or it's a failing, low ejecting heart? Now, all of us know this equation. Just to review, so mean arterial pressure equals cardiac output multiplied by systemic vascular resistance. Cardiac output is stroke volume multiplied by the heart rate. Stroke volume is depending on the preload, contractility, and afterload again. So in shock management terms with ultrasound, we call tank, pump, and pipes. And I can measure the stroke volume using the echo, using this equation, non-invasively. I can calculate the left ventricular outflow tract velocity time integral, and if you calculate the LVOT diameter, you can get the stroke volume. If you have the stroke volume, you get the cardiac output, you have the mean arterial pressure on the monitor, and you have the CVP, or you can even neglect it, and you can calculate your systemic vascular resistance non-invasively. I even, most of times, don't need to calculate. If I have a normal blood pressure with a high stroke volume, I know his systemic vascular resistance is low. Normal blood pressure and his stroke volume is high, or his heart rate and stroke volume are high, I know that this is low, just with eyeballing. If I have a low mean arterial pressure with a high heart rate and his stroke volume is low, I know stroke volume could be normal or high, trying to compensate for that. So you do the calculations at bedside. If you calculate cardiac output, you can do that with PICO, LETCO, Vigilio, whatever the machine you use, or even non-invasively with echo, but you have to know what's my systemic vascular resistance. That all is well known, but systolic failure is not a killer. Diastolic dysfunction and mortality in septic shock, and to my best of knowledge, this is the latest systematic review and meta-analysis done so far, and it is extensive one, including a lot of studies. In this study, they found here, this is a diastolic dysfunction and systolic dysfunction, and comparing between two groups with and without. So in this group A, comparing people with diastolic dysfunction compared to people with no diastolic dysfunction, and the relative risk of people with diastolic dysfunction is actually higher compared to people with no diastolic dysfunction. And sub-analysis of this group shows that people with diastolic dysfunction grade 1 had the highest mortality, not grade 2, not grade 3, because it's happening as an acute event. compared to systolic dysfunction, and there is no relative risk of people who have systolic dysfunction compared to people who don't have systolic dysfunction. So systolic dysfunction, as per this study or this systematic review, is not a killer, while diastolic dysfunction is a killer. How to diagnose diastolic dysfunction? If you remember my E, A, and diastasis in between from the mitral inflow, this is normal. If it is reversed, that's grade 1 diastolic dysfunction. This is mitral inflow, so echo, apical four chamber view. Put your pulsed wave Doppler on the mitral valve and in the right angulation, so perpendicular to the mitral valve, and see if the E is taller than the A, that's normal or pseudo-normal. That's a normal or pseudo-normal. Normal or grade 2 diastolic dysfunction. So if you find grade 1 diastolic dysfunction in this patient, please ask why. Does he have that one as chronic grade 1 diastolic dysfunction? Okay, that is less serious than one who previously was normal diastolic dysfunction, and now we are putting him on adrenaline, causing tachycardia, oxygen demand supply mismatch, and the stiffer LV acutely. This patient carries the worst prognosis as per the current evidence. If you have this one and you don't know if it is grade 2 or normal, you have to do tissue Doppler, and this is what we call the tissue Doppler. So you put your pulsed wave Doppler, but tissue format, so you are measuring the velocity of the tissues, not the blood. Here I am measuring the velocity of blood. Here I am measuring the velocity of the tissues. And if it is a mirror image of this one, so you know now this looks normal or pseudo-normal. If the mirror image is normal, tissue velocity is fine, that's definitely normal. But if you find with your tissue Doppler the E prime is smaller than the A prime, so tissues here on the mitral inflow or mitral insertion point, either in the septum or in the lateral wall, are impaired motility, impaired velocity, and I see that's normal, that's not normal, so that's a grade 2 diastolic dysfunction. You need to consider diastolic dysfunction before loading your patient with 1 or 2 liters of fluids. Rush protocol, the most common or most famous protocol resuscitating patient, 1, 2, and 3 to assess the heart for cardiogenic shock and contractility versus obstructive shock and pulmonary embolism versus obstructive shock from tamponade. Then 4 and 5 here are in the hepatorenal or Borison's pouch and lienorenal or splenorenal pouch to detect any internal hemorrhage and hemorrhagic shock. 6 is urinary post-renal obstruction. So if your patient is oliguric, you examine the bladder to see if there is any obstruction, or the bladder is full with an obstructed catheter, so it's oliguric or anuric just because of obstructed catheter. And 7 is for to rule out any abdominal aortic dissection or cause of this hemorrhagic shock. 8 and 9 to rule out obstructive shock because of pneumothorax or septic shock because of pneumonias. So again, the same tank, bump, and pipes, but in an ultrasound format. And if you look here, I know I took a lot of time, I'm sorry for that. So evaluation of hypovolemic shock, you look bump, so the hyperdynamic heart, flat tank, IVC, and jugular veins are really flattened. You may find peritoneal fluids or the cause of hemorrhage here in the pleura or in the peritoneal sac, and pipes, maybe ruptured aortic aneurysm or abdominal or aortic dissection. Cardiogenic, hypodynamic heart, dilated left ventricle, and his veins are distended, lung rocket signs or B lines. So pleural fluids may be effusions bilaterally and ascites, while the pipes could be normal. Obstructive shock, hyperdynamic heart with the source of obstruction in term of tamponade or big precardial effusions, RV strain pattern in the term of pulmonary embolism, or a cardiac thrombus with distended again inferior vena cava with DVT as the cause of PE, and distributive shock, hyperdynamic heart, and normal or small IVCs because of relative intravascular volume depletion. You may find the peritoneal fluid if it's peritonitis as the source of sepsis, or the empyema is the source of sepsis with a normal pipes, or again contracted pipes if it is talking about IVC. The last two slides, thanks so much for watching all that long. The hemodynamic assessment in septic shock, but you can use that in any case of shock, comparing the transpulmonary thermodilution catheter or Swan-Ganz catheter compared to a critical care echo. And I used this article from 2018, I believe. I cannot see from here. Yeah, it's 2018. With this prospective randomized study conducted over 36-month time or 3 years in multiple French intensive care units. So the beauty of this one, it mentioned all your cut-offs if you mentioned or if you're comparing the pulmonary artery dilution catheter, pulmonary artery flotation catheter or Swan-Ganz catheter versus the echo. And here, this is when you ask for fluid loading. If you are using a thermodilution catheter, this is stroke volume variation, pulse pressure variations versus the echo. So SV, superior vena cava, collapsibility or distensibility index, IVC distensibility or collapsibility index, depending on your patient is spontaneous or mechanically ventilated. Inotropic support in these scenarios, if you're using the pulmonary artery catheter versus echo. And here, this is when you need to consider different things if the patient is acute cor pulmonale or acute massive or submassive PE with a pulmonary hypertension. And this is when you start to introduce vasopressors, and when this is no therapeutic change or no therapeutic modality should be advised. So if you go through these ones, you will find all the cut-offs until 2018. That's a very good source if you want to review that one, or if you want to formulate a research. This is very good, and you can find the references that they used for these figures, but it was an extensive work. And finally, thanks very much, and here is your gift.